afternoon, everybody. Welcome to the second session of the sports extra-articular session. First of all, I would like to thank Dr. Sachin Tapaswi, who can't be physically with us today because of some family emergency at home, but we have listened to his pre-recorded lecture. He hails from Mumbai, Pune, one of the top surgeons in Mumbai, India, and we are fortunate to listen to his lecture. And when travels are open, I'm sure he'll visit us and we'll visit his famous Pune course. And second of all, I'd like to introduce my friend, Dr. Umar Butt. It's a close friend of mine who studied all his life in UK and now is based in Lahore, Karachi or Lahore in Pakistan, and it's given an excellent lecture on ACL Repair, something which he's been doing and shared with us. And also would like to extend our thanks to Dr. Alan Gadgood, who hails from Canada, who has given us a beautiful demonstration on lateral structures dissection and tenodesis of the ITB band as extra-articular procedure for ACL reconstruction. So now we will start with question and answers. Let's look at what questions we have. Let's go to more questions. Umar, can I hear you, Umar? Okay. Is there any questions for Dr. Umar's ACL repair or Dr. Sachin's lateral extra-articular tenodesis? I think the lecture by Dr. Sachin on extra-articular tenodesis is very good because I think it took us to all the lateral anterolateral complex, took us to decision-making. When do we do a lateral extra-articular tenodesis, which I also have a lot of passion in it because it's a whole complex. The Kaplan fibers, all the fibers coming in. So you're trying to reduce the rotation. And I think he's scientifically given you some answers on history, on examination and on investigation, on nature of sports you do, in which patients you will do extra-articular tenodesis. And I think you can use those, but in principle, I think you have a high-grade pivot shift. You are revising in a patient which you don't know what's the cause. You have a patient who's playing pivoting sports and has a recovatum loose jointed knee and a high risk of failure. You will never go wrong anywhere by putting in a lateral extra-articular procedure. So question number 2 from Dr. Reza. Do you external rotate the knee during ALL fixation? If yes, how many degrees? Okay, this is a very interesting question. I generally do ALL reconstruction. My knee is always in about 80-85 degrees of flexion. I leave the iliotibial band attached on the Geddes tubercle. I make sure I have at least about 10 centimeters of graft, enough to, I measured enough that it goes to the lateral epicondyle. And then once I've taken the 1 centimeter strip of graft, I pass it through the below deep to the LCL. And then I normally put a fit interference screw with the foot slightly external rotate, not forcefully external rotated, slightly external rotated, that is sufficient. And I fix it about 85 to 90 degrees in flexion. So that's how I do my ALL, which is like a McAndrews procedure. So basically, when you're doing a lateral extra-articular procedure, you want to reduce internal rotation so that your lateral bone bruise or whatever doesn't get engaged. So you want to fix your graft in external rotation. There's next question from Dr. Jonas Fernandez. What are your opinions on using of intra-op II for primary ACL reconstruction to prevent tunnel malposition? I generally, Dr. Jonas, generally unless I have anomaly problems with bony abnormality, in cases where there were fractures or there's rotatory issues, I hardly use II for my primary cases. I normally use it for my revision cases where there's a tunnel enlargement and there's screws and trying to navigate my waist. But unless in the primary cases where you're not sure of your button is incarcerated or is flipped or stuff like that, I use II. Hi, Umar. Welcome back. Nice to have another person with me. You've ditched me, my friend.
I'm in the mountains area, so the connection is very bad. I'm so sorry to all the participants. So
Okay.
yes, Charanjit, I'm happy to answer.
Yeah, the question was from any use of intra II for primary ACL reconstruction to prevent tunnel malposition.
I think the ACL reconstruction with I will only use in a scenario when I'm worried, or if you are a young surgeon who just started off using adjustable loop endo button or fixed loop endo button. But for tunneling, I think it's very, very unusual because now we have enough instrumentation and jigs. You can use offset, you can do free drilling. So you have other jigs available rather than using an II. The only time I would recommend using an II during ACL reconstruction is if you are worried about tunnel, the endo button is not flipped or it's inside the joint, and you do an x-ray just to make sure it's sitting on the lateral side and not sitting on the soft tissue, especially if you are changing your endo button from adjustable to fixed loop or something new you are using, you're not familiar with it, because it takes some time for a surgeon to get used to a new RT or endo button or whatever you call it. But in routine, I won't recommend usage of II for tunnel positioning.
Thank you, Umar, for that. We have a question from Dr. Ikram. I will let you answer first. When there is a concomitant Sigon's fracture, anterolateral capsular avulsion with a Sigon's fracture, do you opt to do ALL reconstruction straight away?
It's again, like Charanjit and you and Alan Getgood gave the option onto the presentation, that I think in my routine practice, because I work in Pakistan, here the patients are not as high demand as in other part of the world. So I will ask my patient and then do physical examination. If the patient doesn't have any major grade 3 pivot shift, doesn't have any hyperlaxity, this patient is not a revision case, I would not routinely do lateral extra-articular or reconstruction procedure as a routine, because I've been doing this practice for the last 5 years in Pakistan, and I haven't seen a massive failure in my patient, because first of all, they're low demand. They don't go into that level of sporting activities like in developed countries people do, but they're definitely in a professional sports player with grade 3 pivot or hyperlaxity, and females, I would do extra-articular support.
Thank you, Umar, for that. I think basically, Dr. Ikram, the question is, when you see a Sigon's fracture, what is a Sigon's fracture? Is lateral capsular avulsion. So what it tells in our mind, there is an injury into the anterolateral complex. So if you see a Sigon's fracture, you examine the patient. If there's a high-grade pivot shift, I would consider doing, if the fracture is large enough, it's pulled off with a lot of ligament on the Gerdy's tubercle, you may even want to consider repairing, putting anchor and repairing it. I've done that so. But it tells you there is injury to the anterolateral complex. Then you decide whether the pivot shift is great. If I am taking the patient to theater and there is a Sigon's fracture, I will definitely do an anterolateral ligament reconstruction or irritable tenodesis, extra-articular procedure. I will definitely add that on. So that's in my practice, but I think it's good to look at and see what are you looking. If you're seeing a Sigon, understand there's injury, and then you determine whether the injury is big enough to do an ALL. To me, if you're doing ACL, ALL or extra-articular procedure, only adds in another 20 to 30 minutes. I think I will do it in the single stage together with the ACL. Next question from Sazali. This for you, Umar. Do you have a specific timing from ACL injury to surgery for ACL repair to work?
Now, there have been 10 systematic review published in the last 1 year. So huge interest in primary ACL repair. And in our study, the last slide, if you remember, a time-specific response. So ideally, the quicker you intervene, the better. So my cutoff now is within 6 weeks to 8 weeks, but I would go for repair maximum to 6 months. Anybody over 6 months is very unlikely I will go for repair, because the vascularity is not good. The tissue starts to shrink. The quality of the sutures when you pass is not good. And I always keep a backup plan for reconstruction. I consent patient primary ACL repair plus minus reconstruction. So the quickest answer is as soon as possible, but maximum delay 6 months, no more than that.
Oh, that's a good answer. Question from Dr. Rauf, again towards you. Dr. Umar, based on your experience in ACL primary repair, would you recommend repair over reconstruction? And what is your contraindication for repair? So, like Charanjit and other colleagues discussed about thinking out of the box. Exactly the same way when you're approaching the knee, you need to have multiple tools. So my indication is anyone who is above 25, because in the younger patients, the study have shown higher failure rate.
Patient who is non-professional player, I would consider him. In patients who is low demand, I will consider, and under 6 months. My contraindication is multi-ligament reconstruction, and very rarely I would go for that. Patient who are high demand patients or who have got chronic ACL rupture above 6 months will not be a suitable candidate for repair.
Oh, that's good. I think I need to start doing some repairs as well. I've not been doing any repairs, Umar. I need to fly out to Karachi, Pakistan and learn the repairs from you. There's another question again from Dr. Siti. Do you use standard ACL rehab protocol following ACL repair? And what is the rate of arthrofibrosis in a patient with primary repair?
Interestingly, I have never come across a single patient developing arthrofibrosis because, first of all, it's a minimal invasive. It doesn't cause any drilling. I'm doing very minimum trauma to the tissue, and patient mobilize much faster. So imagine the patient doesn't have pain because of the tunnel draining. Patient doesn't have any pain because of the hamstring. Inside the knee, I'm not doing anything apart from stitching the ACL and fixing it with an anchor. So it's actually quite a minimal invasive procedure. And all our patients who we compared them with reconstruction actually had much lesser need for opioids. They went home much quicker, and we put them to weight bear much faster. So the answer to your question is no. It's very, very unlikely that you will develop arthrofibrosis unless you intervene within 5 to 6 days. So I let the knee swelling go down. We give them icing, physiotherapy, let them mobilize, and once in 3 weeks, 3.5, 4 weeks, the swelling is down, then we intervene. So it's very unlikely they will.
So we have any different, Umar? Do you rehabilitate differently? I mean, in terms of do you brace them, or do you go slower, no. Or is there anything different you do in your repair versus reconstruction?
Yeah, exactly the same as reconstruction, but I let them weight bear much faster. So they feel that they can weight bear much easier. They don't have pain in the hamstring, so I let them bend the knee much faster. So for example, in reconstruction, I would ask them to fully weight bear within 10 days. But with repair, I can ask them to start weight bearing as pain allows. So for example, if the patient is saying that I'm able to fully weight bear the next day, I would let him. That may give them a better edge to recovery comparing to reconstruction. But the protocol for repair and reconstruction with regards to the rehab is almost the same.
Good, thank you. Unfortunately, I think I'm not sure. I don't have much experience in repairs. I think that's probably the way to go. I think Professor Xavier Wu from Pittsburgh, who is also a colleague of Dr. Freddie Fu, has basically talked a lot about repairs, and that's probably the way to go. And I like your part where you actually do a microfracture to get all your pluripotent cells coming in to help your repair. All right, let's go to a question from Dr. Raghuman. I missed this question. Mr. Chanjo, this to me. In your experience, do you operate bilateral ACL reconstruction in one stage? The answer is no. I am a strong believer that I think you need to keep your patient sane. And if you put to a young fella both knees together, he's going to suffer. Bilateral surgeries is not. I'm not ready. I will get Umar's opinion after this. I'm not very good with bilateral surgeries, and definitely not in ACL, because I think you definitely need your other knee. Even though you're not going to do pivoting and spotting spots, but you need your other leg to move around to rehabilitate these. So it's never a good idea to do a bilateral ACL reconstruction. Umar, what's your thoughts?
I 100%. In this part of the world, there has been an interest towards surgeons doing bilateral knee replacement, bilateral hip replacement, bilateral ACLs, but I feel it's completely not required. First of all, you will very rarely see patients with both ACLs gone. You do see them, but maybe if you do, my volume of ACL is very massive, and I see maybe one patient who will have bilateral ACL in a year. So what's the rush? Do them good, do them relaxed, let them rehabilitate, and then move to the next stage after 3 months. There is no need to put the patient through such a massive operation and slow their rehab. I would never do bilateral ACL.
Okay, let me see. So what's your opinion, Dr. Umar? What do you think? Is the ACL, where do you think, which patients, because I saw in your video, most of the one you're repairing is on the femoral side, your type 1, type 2. What is the role? Which patients, like a person like me, who's probably going to start doing some repairs? I mean, in children, yes, but which patients you think would be the ideal candidates for repair versus reconstruction in your practice?
Yeah, so Charanjit, in repair group, as I said, first of all, obviously, is patient perception about this surgery. So anyone who's above 25, younger patients have much higher risk of failure, and Gregor de Phillis in his series have shown that. And recent systematic review, which has been published, has shown that a younger patients who are under 25, who are into more running and sports, have got much higher risk of failure of primary ACL repair comparing to over 25. So my first choice is age. Anybody over 25, 30, 35, who is low demand, who is not into professional. That's number one. Number two, what type of tear we can repair? So type 1, which is not off the wall, the ligament is still attached, but there is a bit of a looseness. Type 2, when almost more than 30% fiber is separated, but there are some streaks of fibers. Mid substance, I would never repair. So the two most indication is type 1 and type 2 tear. When you go inside with the help of keyhole surgery, you are able to see most of the ACLs, which is fresh, that they are lax, but they are attached. These are the ideal candidate which I would prefer to repair. But don't get into confusion. Sometimes we are very busy. Never underestimate that they can have tibial sided tear as well. So always carefully read MRI scan, examine the patient intraoperatively, thoroughly. With the probe, examine if there is any tibial sided avulsion, because if you do that, then when you stick the ACL back, the tibial side lifts off. So it's very important that you should not rush into doing repair unless you have done all the tick boxes. Clinical examination, MRI scan. And another interesting thing, type 1 tear and type 2 tear will hardly have grade 2 pivot. They will only have grade 1 pivot, and that you can also justify that their knee is stable enough. Clinical examination, they will not have grade 3 Lachman test. They will have a nice, easy Lachman, and you will see MRI scan which will match their clinical examination and intraoperative as well. And then you make that decision. Because it's very easy to switch to reconstruction on spot, but it's very difficult to do a bad repair and then worry about the patient. You haven't burned the bridges. If you do a good repair in a 35-year-old and he comes back to you after 2 years to say that his knee, the ACL has torn, you still have a chance to do reconstruction. You go inside, you cut the ACL, you remove that tiny bit of anchors, cleaning it up, because the tunnel size of the anchor is 4.5 millimeter, which you normally use for your reconstruction. So, and you haven't done any major damage to the knee. So you can easily go and do reconstruction, but you have to counsel with the patient that the failure rate of primary ACL repair is almost 10% comparing to reconstruction.
Umar, can I ask you a question? Just
Yeah,
out of
please.
curiosity, what made you go into ACL repair? What is the 2 or 3 main things? Is it you feel it's a reconstruction is not original, or what made you go into repairs? You yourself.
Charanjit, during my training, when I was doing meniscal repair a lot, and in the beginning, as you know, in early 2007, 8, 9, 10 period, a lot of patients, when we used to do arthroscopy, we used to do a lot of meniscectomy. Even for a bucket handle tear, our senior consultant used to say it's not repairable, remove it. Then we started showing interest toward doing repair of the meniscus. Then we started adding scaffold. Then we started putting meniscal transplant. During that time, in my early fellowship program, I noticed that majority of the ACL which were attached used to be cut by my boss as a nibbling effect. So they used to nibble the tissue, remove it, and then used to put a new ACL. And then obviously I looked at the literature, read some new articles on it, and then I started realizing that actually why we cannot stick the ACL back like we do cuff repair, because I do exactly the same practice like you, shoulder and knee. So when we can vascularize tissue, if we can save it, why we should replace it? So if that fails, then reconstruction is an option. And on the basis of that, obviously 2.5, 3 years ago, I started doing repair. So if I do 300 plus reconstruction, I would only do 10 repair a year. So you can imagine it's not massive volume. I would be very, very selective. But in a day, I come across that I've done 3 repairs. But there have been months in which I haven't done a single. So I'm not only focused that I would do repair in everyone. It should be patient selection of indication, indication, and indication. You just can't do repair with everyone. But the reason behind that was that I saw a patient coming in the OR, and I used to see their ACL. The ACL looks so nice and vascular, attached to the femur, but lax. And I used to use a biter and cut it and put a reconstruction. And these were the few things which were going in my mind. And obviously, recently, in the last 5 years, other colleagues started publishing their work. The difference between me and my colleagues are they use either internal brace, which is almost like a drilling and putting an endo button. They use 2 anchors, which is 4.5 swivel lock, or they use DIS. And I wanted to change the style, by not doing tunneling, because the purpose of repair is not to drill the tunnel. The purpose of repair is not to put the endo button. The purpose of repair is not to put the screw in the tibia. Otherwise, it's almost like a reconstruction. So I wanted to create a technique in which I would do minimal invasive surgery, low cost surgery, because single anchor is much low cost and easy to revise. And that was the reason I developed a single anchor with the help of this relax anchor, which is actually used for shoulder cuff repair. The benefit of this anchor is not only that you can accommodate 4 suture ends, but you can also do tensioning effect like a cuff repair. So once you've done that, and if you know your ligament is a bit lax, you tension it and it sucks it back. And interestingly, Charanjit, you won't believe that when you see them in clinic, you can't recognize that do they have ever had an ACL injury. They are so stable.
Yeah. Apart from stability, do you think the proprioception is better being the native ACL repair?
Definitely. They don't feel pain. They feel their knee is natural. And in our part of the world and also Malaysia, they easily pray very quickly. So when they are on the squats position, they don't feel pain.
There's a question here from Dr. Rauf. Abdul Rauf, do you have any good outcome for repair of middle tear of ACL, mid-substance?
I would never substance, because in 1990, when the studies was carried out by Sherman and he looked at the literature, the most highest number of failure happened in the 4 studies published was mid-substance.
So where do you think, Umar, where are we going with this ACL repairs? Do you think it's going to be something of future, something we need to look at it further? Where do you think? You see around 310 repairs. Do you see like maybe half and half will be repairs in future, or what? Where do you think you're going with this? Umar? Where do you think we are going with repairs? Yeah.
One thing is for sure, Charanjit, that in the last 15 months, 10 systematic review has been published. So first thing, surgeons are showing interest in repair. Number 2, the way we are saving meniscus, the way we are saving cartilage, the way we are doing biological knee replacement, ACL will be a hot topic of repair. Majority of the top conference, ISACO, CCOT, APUA, you will see a whole section of primary ACL repair. So we are heading toward the future. The 2 procedures started together in 1970s, and one is now on the top reconstruction. ACL is picking up. My personal feeling is the way our biologics is getting better in hand, the way the surgical technique is improving, the way that the implants are getting better, I personally feel there will be a huge interest toward repair in the next 4 to 5 years. And it will become a very, very recognized procedure to be done by any knee surgeon who does soft tissue reconstruction.
Thank you. Thank you very much for a very interesting explanation. And thank you very much for joining us from Pakistan. It's nice to see you. I think we are done. Your time is up. And thank you everyone for listening. Thank you for MOA for having trust in us to give these lectures, and being the chairperson and calling some of my friends to come over and do this. And thank you everybody, and have a good evening. Umar, bye-bye. See you.
Bye-bye.